4, 3, 2, 1. Sir, we are live now.
Okay. Thank you, Maharshi. Good morning, all. Myself, Dr. Chinmay Sangole. I'm a practicing pediatric orthopedic surgeon in Amravati in the state of Maharashtra. In today's fellow teaching model at Orthokids Clinic, we are discussing day-to-day orthopedic cases we are encountering daily in our OPDs. So today we have two faculties. First is Dr. Shalmi Mehta. She is a MD pediatric, but at the same time she done her fellowship in endocrine from Rickets Hospital, Toronto. She is the first lady in the whole of the Gujarat who started slowly practice of a pediatric endocrinologist. She is a national and international faculty in various conferences, and she is having a numerous papers by her name. At the same time, she teaches a lot of things. When my time over there in the field of endocrines, what are the importance of vitamin D, or what are the different types we can control, and how we are monitor this child in rickets, and what are not the cases in endocrines. So, and the next faculty is Dr. Atul Bhaskar, who is a pediatric orthopedic surgeon. Sir is trained at Hospital of Sick Kids, Hospital for Sick Children at Canada. At the same time, Institute of Calotte, France, and Gilead Children's Hospital for Cerebral Palsy. Sir also is a postdoc fellow in Texas Scottish Rite Hospitals. So today we have two guests, and first lecture will be by the Dr. Shalmi Mehta. Over to you, ma'am. Thank you.
Yeah, thank you so much, Dr. Chinmay. I'll just share my PPT first.
Yeah,
so I think we talk a lot about rickets. It's a very, very simple condition to take care of. But often we end up having a lot of confusions and a lot of doubts on how to exactly manage these conditions. So today we are just going to go through 3 simple different cases, and that is how we'll learn how to approach a child of rickets. So before we go to that, we know that, how is a bone formed? I think you people know better than me. There is the osteoid, which is laid by the osteoblast. On that, mineralization happens. And this requires important concentrations of calcium and phosphorus. And remember, vitamin D is a key factor. Right? So when we talk about vitamin D a lot, we need to know that the basic function of vitamin D is absorption of calcium and phosphorus from the gut. So for example, say somebody is taking 1000 milligrams of calcium every day. In a state where the vitamin D levels are normal, about 60 to 70% of the calcium is absorbed from the gut. But if that child is severely depleted in vitamin D, the absorption is reduced to only 10%. So even if you're taking 1000 milligrams of calcium, only 100 milligrams of calcium is absorbed if you have a vitamin D deficiency. And it also helps in absorption of phosphorus. So even in vitamin D depleted conditions, you'll have a phosphorus deficiency also. So, mainly for the absorption of calcium and vitamin D and phosphorus, vitamin D is needed. Vitamin D has now shown to have a lot of immunological benefits also, but we are not going to go into details of that. If we just look at the basics, right? So what exactly happens? We know that we do not get vitamin D from our routine foods. There are only very less seafoods from which vitamin D is available. Most of us don't consume those foods, so we rely either on the sunlight or through supplements. So sunlight falls on the skin, and it is on the skin that vitamin D is synthesized. It goes into the liver, forms 25 hydroxylase vitamin D. It goes into the kidney, forms 125 dihydroxy vitamin D. And remember, this is the active form of vitamin D, which is then going to cause absorption of calcium and phosphorus. So just having vitamin D is not enough. We need to have a normal liver, a normal kidney, and the normal enzyme systems. And also, we need to have the receptors, right? So that this activated vitamin D, that is called calcitriol, can act properly. So if you just know the basics, you can very well distinguish between your different types of vitamin D deficiency or whether it is vitamin D resistant rickets, right? Now, again, this is very, very important. What kind of waves of the sunlight are going to initiate the synthesis of vitamin D? That is usually the wavelength of 290 to 315 nm. Now, remember, we get this maximum between 11 to 2 p.m. Most of the time we are in the office or kids are at the school. So when we say, no, subah ka, sit at 7 o'clock in the sun and you'll get the vitamin D, but all those rays are very, very slanting and they are practically of no use in synthesizing vitamin D. So it is usually the solar noon UVB rays which are useful to synthesize vitamin D. And most of the times we don't get that exposure, right? And therefore, even though we are such a country with such abundant sunshine, most of us end up having vitamin D deficiency. Another thing, genetically also, we have certain genes which will deactivate the active vitamin D. So we are genetically made like this. So that is again one of the reasons why you check a vitamin D of a routine person, and that is going to come on the lower side. So if you want to just define, when you have an adult and there is a failure of calcification of the osteoid, it's called osteomalacia. But when you have an immature bone, when you have a growing bone, we give the terminology of rickets, right? That, okay, this is rickets. The osteomalacia in the developing bones is called rickets. Now let us just go through different cases, and these are very, very common cases that we encounter in our clinical practice. So I have got a 1.5-year-old girl. She has a first episode of generalized tonic seizures while playing. Right? She's otherwise a well, healthy girl. She comes with a lot of irritability, excessive sweating. There is history of recurrent upper respiratory tract infections also. She's otherwise fine. There is no significant family history, no significant past history. She's gaining milestones well. But yes, at 1.5 years, her teeth haven't come. So there is no dentition as of yet. And there is slight delay in the gross motor milestones. She's not able to walk well. Parents report that there is a waddling gait. Right? Now, I think as pediatrics, as somebody who deals with the pediatric patients so routinely, it's very, very important that we start using growth charts, because so many of our kids are having short stature, they have growth failures, or they're recovering from chronic conditions. So I would request all of you to start using growth charts. They are very, very easily available from the IIP websites, and everybody can use it. So the upper portion is the length, the middle is the head circumference, and the lower is the weight. So what I want to stress is the child's weight is fine. So the child is not very undernourished or malnourished, but definitely the height is affected. The child is short for the age. And so these are the centiles. The weight is okay, but the length is definitely on the lower side. It should be around 81 centimeters. This is only 72.5 centimeters. And this is also one of the presenting features sometimes in rickets. Kid would come just to us with short stature, and we find out that the child is short because of rickets. Now, on examination, this child is well nourished, but yeah, a bit irritable. There is a wide open anterior frontanelle. So by 1.5 years, we expect the frontanelles to close, but this child still has a wide open AF. There is a frontoparietal bossing, beading of ribs, the typical features that makes us, make a spot diagnosis of rickets. And you can appreciate the widened wrists, the double malleoli. I'm not sure if the beading of ribs is very evident or not, but yeah, a well-nourished child, but has typical symptoms of rickets. Just a second. Yeah, Chinmay, just a second. Yeah. So I just wanted to share the yeah, I'll just share it again. I think something happened.
Yeah, sure.
Yeah. So I was trying to show the video of the child walking, and it stopped. So let me try again if I'm able to show the video of the child. Yes. So if you can appreciate the typical waddling gait.
Ma'am, we are not able to see the video.
I'm not able to.
You have to share your screen share.
Yeah, I'll do that. Yeah, is it okay now?
Yes, ma'am, you can.
Yes. right? So the typical waddling gait that you usually see in these kids, right? I hope everybody is able to appreciate it.
Yeah.
Yeah, I think when I'm, and this is the X-ray of this child, right? So you can see all the typical signs of rickets, the flaring, the faying, and if you just want to compare the X-ray with somebody of the same age, so you can see the severe rickets that this child had, which was otherwise normal. Now, on investigations, the hemoglobin is slightly on the lower side, 10.8, liver function test, kidney function test. We generally prefer to do a bicarbonate and electrolytes because sometimes we do see a rare case of renal tubular acidosis presenting to us with rickets. So that is why this has become a part of our routine investigations. Now, when we went to the main investigations, we noticed that the calcium was 6.4. Now, remember, any calcium of less than 7 can cause hypocalcemic seizures. And that is how the child actually presented to us, right? The phosphorus is also slightly on the lower side. She has a raised alkaline phosphatase. The child is not losing calcium in the urine. So we did a urine calcium creat ratio. The child is not losing calcium. The vitamin D level is significantly on the lower side. You can see it's only 3.4. And as a response to the low calcium, you can see a high PTH. So here the parathyroid hormone is raised, which is as a response to low calcium. Now we know that the parathyroid hormone has a very important role in maintaining normal calcium levels. So what does it do? It helps in making active vitamin D, that it helps in making calcitriol. The moment it notices that the blood calcium level is dropping down, it releases calcium from the bones, right? Because we know that the bones are a big calcium bank. So PTH induces the release of calcium from the bones. And the third, it decreases the loss of calcium in the kidneys. So PTH has got these three important roles. And thereby it tries and maintains the calcium levels in the normal range. But now all the bones are also depleted of calcium, and therefore eventually your serum calcium levels also drop. So when you see a calcium level in the blood also in such low levels, you can always understand that the bones are all depleted of calcium, and this is the patient of very severe rickets. But here, instead of worrying about the PTH, because it's a normal response to a low calcium level, right? So this is a case of vitamin D deficiency rickets causing hypocalcemic seizures. So it's a case of vitamin D deficiency rickets. And this is very, very clear. The most important thing is to how to manage these. We all know what are the different causes. I think the first and most important cause is decreased synthesis. We as dark-skinned people have a lot of melanin. So we are going to reflect away the UVB lights. We don't, usually we have a cloud cover or we'll be wearing full sleeve clothes. We don't have a routine plan to supplement our kids with vitamin D. So low oral intake, somebody who's exclusively breastfed. So we all insist on exclusive breastfeeding for our babies, but vitamin D is one thing which we don't get in the breast milk. So all exclusively breastfed babies have to be given vitamin D from birth. It could be malabsorption or maybe some rare cases like liver or kidney diseases. Now let us see what exactly happens when somebody goes to develop vitamin D deficiency. So what are the different stages? What happens to the calcium, phosphorus, and all the other metabolites, and what happens to the bones also? So when you have the initial vitamin D deficiency, the first sign that happens is impaired absorption of calcium. Right? Causes slight osteopenia on the x-rays, but it may not be very much visible. So you will have an x-ray, but the absorption of calcium has now started decreasing. The second stage would happen is the PTH levels rise because now you're not getting calcium in the intestines. So we need to mobilize the calcium from the calcium sources. So PTH comes into the picture. It tries to normalize the calcium. And therefore, now here you can start seeing some signs of rickets on the X-ray or maybe even some clinical features of rickets on the child. Still, nothing is being done. Then the serum calcium is going to fall because all that rise in the PTH is not able to compensate for the impaired intestinal calcium. And here you will have your severe radiographic and physical signs of rickets. So this is how step by step, if you do not correct vitamin D deficiency, a child develops severe rickets. But I think the most important thing to remember is the clinical, The biochemical and the radiological findings may not correlate with each other. So you can have a severe vitamin D deficiency, but still the X-ray may not show symptoms of, the signs of rickets. So remember, this may not correlate with each other. We had guidelines from Indian Pediatric Society. They say that deficiency is less than 12 nanogram per ml. Between 12 to 20 is insufficiency. More than 20 is sufficiency. Now, remember, when we see toxicity, it is not the vitamin D which is toxic, but it is the resultant high levels of calcium. The subsequent high increase in the calcium levels, which causes all the irritability, the excessive sweating, the nephrocalcinosis, the weight loss. So it is the high calcium because of high vitamin D, which is causing all the toxicity. So our aim is to have our vitamin D levels at least more than 20. Routine screening is not recommended, but yes, you often get these patients where you may want to screen them for vitamin D. Ideally, vitamin D has to be given to each and every child. But yes, you would want to do a test for these people who are at risk of developing vitamin D deficiency. So I'm not going much into the details of that. If we talk about how to give vitamin D, now remember, oral is always preferable than giving a large dose intramuscularly. We need to give intramuscular vitamin D only if the child has malabsorption, like somebody has a celiac disease, or you are not sure about the compliance. Only then give that large dose intramuscularly. Vitamin D can be given at any time, independent of the fed state. So you can give it with the meal or without the meal. It doesn't make a difference. Now, to prevent vitamin D deficiency, what are the doses recommended? For the younger babies, 400 units per day, every single day has to be given. Between 1 to 18 years, we give 100 milliunits. Now, remember, when the child hits puberty, we need to increase that dose to at least 1000 units per day. So this, I'm saying that this child needs to get 1000 units per day vitamin D every single day throughout the puberty, and then to be continued also. Along with that, we need to ensure that the child gets enough calcium, either through dairy, so either you're taking through your oral intake, or if not, then through supplements. How do you treat vitamin D? Now, here I want to give an important message is that for the younger babies, when they come to us with severe vitamin D deficiency or rickets, we will prefer not to give them large doses of vitamin D, right? So especially for the younger babies less than 1 year, we would prevent giving them 60,000 units per day or per week. Rather, we give high doses daily, and then we switch to a maintenance dose so that deficiency doesn't happen again. So if you look at the 3 to 18 years category, we sometimes end up giving large doses of daily vitamin D also to treat the vitamin D deficiency, and then this has to be followed by a maintenance therapy to prevent vitamin D. Now, you have treated the vitamin D, but if you don't put this child on maintenance, he's going to have vitamin D deficiency again. So remember, it is not just treating the deficiency, it is also then giving maintenance to prevent further deficiency, which is again very, very important. We can give our weekly preparation. So especially for the older kids, we prefer to give 60,000 units of weekly for about 6 to 8 weeks. But again, this has to be followed by daily maintenance. This is very, very important. Right? Yes. So again, as I said, large doses will not be used for preterm neonates and for kids less than 3 months. We can give larger doses, but let us not give it daily, but maybe once in a week for 6 to 8 weeks. But again, I will keep on stressing again, because this is the reason why kids come to us again with vitamin D deficiency, that we fail to give a maintenance dose. We need to stress that we don't get this in the food. So once the deficiency is taken care of, let us just keep on taking some vitamin D to prevent a deficiency again. Therapy has to be individualized. We have to ensure compliance. And yes, Another important aspect that I want to stress is many patients who are referred to us as vitamin D resistant rickets are actually inappropriately treated vitamin D deficiency rickets. The reason being, we give them vitamin D in large amounts, but we fail to give them calcium, or we don't give calcium in adequate doses. Now, remember, as we said, that the calcium levels drop because all the bones are now depleted of calcium. So the moment you give them some calcium along with vitamin D, all the calcium gets driven into the bones. And again, the blood calcium drops, and then you feel that, okay, this is not working. Maybe this is a resistant rickets. But we need to make sure that we are giving adequate amounts of calcium to avoid hungry bone syndrome. So sometimes we end up giving, so these are the routine doses that have to be given, 30 to 75 milligram per kg per day, but we sometimes end up giving even 100 to 150 milligram per kg per day of calcium if you have a patient of severe rickets, and then you can decrease the doses as your PTH and your vitamin D levels normalize. So remember, very, very important to give adequate doses of calcium. We usually continue calcium for 3 months along with that initial, the deficiency treatment phase. And then if the child's oral intake of calcium is normal, we can stop calcium and then just continue with vitamin D. But very important to give adequate amounts of calcium. If the child is having symptomatic hypocalcemia, for this child who had a seizures, we may sometimes need to give IV calcium also. We give calcitriol for the initial 7 to 10 days if the calcium levels are very, very low, because it is going to take about 4 to 5 days for your oral vitamin D to start working, right? And it's an emergency. The calcium levels are 6.5. So we may need to give the active form of vitamin D, that is your calcitriol, till calcium levels normalize. So not more than 7 to 10 days, but only till that phase, till your vitamin D starts to work. So, typically in that particular patient where you had such low levels of calcium, we would give them calcium, vitamin D, and about 7 days of calcitriol also, right? So this was the X-ray at presentation. And then at 3 months, you can see almost normal X-rays for that particular child, right? You can see the X-ray improvement in the knees as well. And even the gait has started improving. Right, the child is now walking normally, the waddling gait is not there. Yes. Talking about surgical intervention, usually not needed. We have Dr. Maulan with us, so he helps us when and needed, but routinely we would wait until the age of 4 to 5 years for the deformity to get corrected, because they usually regress completely. And yes, it's a chronic process. It may take months to years, and therefore we usually wait until the age of 4 to 5 years. And only then, if the deformity persists, we might need to do some corrective intervention. So what actually happens is, in 6 to 10 days, the calcium and the phosphorus starts improving. You start seeing healing on the X-ray by 4 weeks. In 1 to 2 months, your vitamin D levels and your PTH starts normalizing. Your alkaline phosphatase might take 6 to 12 months, because it's a marker of active bone turnover. The bones are healing. So it may take 6 to 12 months for the alkaline phosphatase to get back to normal. And this is what we routinely do in our practices. We repeat a calcium, phosphorus, and alkaline phosphatase at a month. And then at 3 months, we would repeat the X-rays and the other blood parameters to see how the child is doing. But yes, if the radiographs are not showing signs of healing, or if the other biochemical parameters are not improving, remember, we need to first make sure that the child is compliant to therapy. The rare forms of rickets are there, but they are not that common. So make sure that you have given adequate doses, make sure the child is taking the medications properly, rule out malabsorption, and then look for the other forms of rickets. So let's go to another case. Chinmay, let me know if I'm going too fast or too slow.
No, it's fine, ma'am.
Okay,
Yeah,
okay.
fine.
So we'll quickly go to another case. I've got a 3 years and 8 months old female. She has history of multiple bony deformities, history of fractures and long bones 2 times in the past also. She's very irritable. She has delayed milestones, delayed dentition. Again, she's falling sick very often. Now, I'm mentioning here history of frequent illnesses because, as I said earlier, vitamin D has shown to have good immunological benefits also. So in a child who has vitamin D deficiency, we do see frequent recurrent infections, especially upper respiratory tract infections, to the extent that even cardiomyopathies are also known in vitamin D deficiency, right? So just keep that in the mind when you encounter a child of vitamin D. And then, yes, because the child had rickets, she has mostly received a lot of vitamin D previously. And if you can look at the growth chart, you can see that, the child's height percentile is quite on the lower side. So at 3 years and 8 months, the child is quite short for her peers. The weight is also on the lower side, but not very bad. But the height is definitely affected a lot. And if you can see, that irritability is there on the face, the severe genu valgum, the widened wrist, the pot belly, if you can appreciate. So, and you can see the widened wrist here, typically all signs of rickets are there clinically also. And this is the X-ray which shows severe rickets. So she is 3 years and 8 months old. Both in the lower limbs as well as in the upper limbs, you can see there is severe osteopenia. Now, when we went now, because you're looking here, you want to expand the possibilities also. If this child has received multiple doses of calcium in the past, so you want to get all the profiles done. You want to rule out your liver, your kidneys. So you would do a bicarb. Sometimes you can come across a patient of renal tubular acidosis, because the body is losing calcium in bicarb, and that is causing the rickets. So always make sure in these patients you're getting these basic investigations done, your SGPT, your creatinine, your bicarb, and your electrolytes. That is a must. So this child had reasonably reports this. Now, when we looked at the calcium, it was only 7.4 milligram per DL. The phosphorus is also on the lower side, and the alkaline phosphatase is markedly raised. We did a urine calcium creat ratio, but the child is not losing calcium. Since this child already had a history of multiple vitamin D ingestions, we decided to investigate a bit further. So we went for the levels of 25 hydroxy vitamin D and 125 dihydroxy vitamin D, because we wanted to know what exactly is the cause of the child not responding. The PTH is definitely on the higher side. So what you can see is the child has 25 hydroxy vitamin D of more than 100, but the active form of vitamin D is very, very low, right? So here, D-dependent rickets type 1, wherein this conversion is not happening. Vitamin D dependent rickets type 2 is where you're making a lot of 125, that is, you're making a lot of active vitamin D, but it is not able to act on the receptors. So when you have a receptor deficiency, that is your VDDR type 2. When you're not making the active vitamin D, that is your VDDR type 1. Right? So this is how we started managing this child, and this was at presentation, the calcium, phosphorus, alkaline phosphatase levels. So we started with a dose of 100 milligram per kg per day of calcium. We started this child on calcitriol. Now remember here, there's no point in giving large doses of vitamin D because the child already has a lot of vitamin D. It is not making the active vitamin D. So here the mainstay of treatment would be to give calcium and the active vitamin D, that is your calcitriol. But yes, we decided to give some vitamin D for its immunological benefits also. Now at 6 months, you can see that now the calcium is normalized, it's 8.9. Even the phosphorus has normalized. So as I talked earlier, vitamin D is responsible for absorption of both calcium and phosphorus. Alkaline phosphatase is down. The child has started improving in terms of weight. Height is still trying to pick up. And now we have started decreasing our doses of calcium, right? A growth modulation surgery was done at 8 months follow-up. At 1 year, most of our parameters have normalized. The child has started picking up on the height as well. She has gained 3 centimeters height now. At 2 years, you can see, she grew 9.5 centimeters. So that's an indirect evidence that my bones are healing. I'm now decreasing my doses of calcium. And at 3 years, I'm just on my basal dose of calcium along with calcitriol, and all my blood parameters are absolutely normal. So this was a child earlier and this is a child now. So this is after growth modulation that we needed that to correct the deformity. But the x-rays have showed marked improvement, right? But here we'll be giving them calcium and calcitriol for the rest of their lives because this is a genetic form of vitamin D. The child is not going to make active vitamin D anytime. So we need to keep on replacing. We need to keep on monitoring these children every 3 months. We do a sonography of the kidneys also to rule out nephrocalcinosis at least annually. So this is how we would manage a patient of vitamin D dependent rickets. If we talk about vitamin D dependent rickets type 2, where you have ample amounts of the active vitamin D, but it's not able to act on the receptors, that would be a much more difficult thing to manage. Sometimes you end up giving IV calcium also to these patients. So yeah, always involve us whenever you're dealing with those patients. So moving on to the last case, I've got a 6-year-old girl. She has complaints of outward bowing of the legs noticed since early childhood, gradually progressing. Otherwise, she's fine. There is no significant family history, no history of fractures or bone pains. She's slightly on the lower side in terms of the height. So then again, as a pediatric endocrinologist, I'll just keep on stressing, start using growth charts in your pediatric orthopedic practice also. And this is how the child presented to us, whitening of the wrist, double malleoli, there is a genovalgum. Otherwise, the child is absolutely fine. So now here, when the child is absolutely fine and suddenly at 6 years, the child develops genovalgum or any deformity, you start thinking out of the box and not just think about vitamin D. And this is the X-ray picture. You can see there is rickets, definitely, but not like a very bad rickets. So on investigations, we did notice a low calcium, a low phosphorus, increased alkaline phosphatase, a low vitamin D, and a high PTH. So initially, this was thought to be a vitamin D deficiency by the pediatrician, and they had given them vitamin D along with calcium supplementation. So when the child came to us, the calcium level had normalized, but what we noticed was a persistently low phosphorus and a high alkaline phosphatase. Now remember, even the PTH, which was high, has now normalized because vitamin D deficiency has been corrected, right? But we noticed that rickets was persistent. We noticed that the phosphorus levels were still on the lower side, right? So in spite of giving calcium vitamin D, the X-rays have also not improved, right? So this mostly is a child who has a hypophosphatemic rickets. We are not going into the causes of hypophosphatemic rickets because they are usually genetic. It could be either an isolated hypophosphatemic rickets or as a part of a generalized renal tubular disorder, where because of a problem in the renal tubules, the child is continuously losing phosphorus. Now we need both calcium and phosphorus for normal healthy bones. So if the child is losing phosphorus, your bones are going to be weak. You're going to have rickets. So how do you treat these patients? Now, definitely before you treat them, you would establish that the child is definitely losing rickets. So we do calculate the serum phosphorus, the serum creatinine. We do a timed urine collection of the urine to calculate what is the excretion of urine in the phosphorus in the urine, and also urine creatinine ratios. Then we would calculate the tubular renal absorption of phosphorus. There are various formulas to do that, and only then establish that, okay, this is a child who has a hypophosphatemic rickets. We would do the genetic analysis if available and if affordable to confirm our diagnosis, because these are all lifetime diagnoses, right? So then eventually these patients would go on oral phosphorus. Now, initially we had difficulty in making those dual solutions, but now we have got phosphorus sachets which are available. So we can easily mix that in the water and the child can just drink it. But remember, phosphorus needs to be given 4 to 5 times in a day along with calcitriol. So here we won't be giving the routine vitamin D. We need to give phosphorus plus calcitriol. And then a very strict monitoring has to be done to see how the child is doing, right? So to kind of summarize, if you have a child who has got a suspected rickets, the alkaline phosphatase is raised, you have got clinical and radiological findings, you would get these basic stuff measured. So you measure your calcium, phosphorus, vitamin D, PTH, make sure that the liver, kidneys are fine, the child is not losing calcium in the kidneys. If the PTH is high, the phosphorus can be normal or low. Probably you're looking at a calcipenic or hypocalcemic rickets. right? So usually, as I said that if the calcium is low, your PTH is going to be high. But remember, if your phosphorus is low, your PTH will be normal because that is what PTH wants. PTH causes phosphorus excretion. So if the phosphorus is being excreted, the PTH is normal. So just looking at the PTH levels, you know whether you're dealing with calcipenic rickets or phosphopenic rickets, right? So if the PTH is high, you're looking at vitamin D deficiency or calcipenic rickets. If the PTH is normal or just mildly elevated, and if the phosphorus is low, you're looking at hypophosphatemic rickets or phosphopenic rickets. And yes, if you have a liver or kidney disease, you'll treat that along with your rickets. Otherwise, your rickets is not going to improve. If you have calcipenic rickets, you'll check your vitamin D levels. If they are low, you know it's vitamin D deficiency. You treat the child with calcium vitamin D. But if your vitamin D levels are high or normal, you would do a 125 dihydroxy vitamin D, because in spite of high levels of vitamin D, why the rickets is not improving. So you would do a 125 dihydroxy vitamin D. If that is low, so 25 to 125 conversion is not happening. That is VDDR type 1. But if even that is high, so body is making a lot of 125, it is not able to act. So receptor deficiency, that is your VDDR type 2 rickets, right? If I talk about the phosphopenic rickets, yes, we would do a bicarb, because if the bicarb is affected, you're looking at probably a generalized renal tubular disorder, right? So whether there's metabolic acidosis or not, then you would investigate accordingly, treat accordingly. And if not, probably you're looking at just a plain isolated hypophosphatemic rickets and treat accordingly. Thank you so much. And I hope, yeah.
Yeah, ma'am, that's excellent talk, ma'am. We have some questions, ma'am, in the chat box.
Yes.
Yes, ma'am. Wait. Yeah, though, can I have an idea regarding the time of sun bath? At what time and
Yes.
how long it should be exposed under sun ray?
Yeah, so as I said, you know, getting a sun bath early in the morning would be of no use. We need to have sun exposure of at least 30 minutes where you're not entirely covered, right? But that is between 11 a.m. to 1 p.m. So that has to be done to get vitamin D. But again, that is often not possible, and therefore a routine supplementation of vitamin D is always advisable. But yes, these are the guidelines for the sun bath exposure. After
Next
8
question
weeks
is,
of, yeah.
After 8 weeks of vitamin D, if we want to continue high dose of 6 lakh, how frequently we can give 60,000, how we can give? What is the
Yes.
importance of K27 compound?
So I don't know what is K27 compound. So if you know about it, but say after 8 weeks of my vitamin D deficiency treatment, I want to continue a higher dose of 60K. I would do that. You know, I would give 60,000 units at least once in a month as a maintenance, right? But always remember, for the younger population, for the pediatric population, we prefer to give a daily maintenance therapy. So only these high doses when there is an issue of compliance.
Okay, ma'am, one question from my side. You mentioned about calcium and create secretion in urine, that ratio. So do we have to do routinely this test for the patient we are seeing for rickets?
So look, especially if somebody who is on calcitriol, right? Because that is going to affect your kidneys sometimes. So if you are on calcitriol, if your calcium levels are too high, you can secrete the calcium in the urine also. So for those patients, we would be doing a UST KUB and a urine calcium create ratio at least once in 6 months to make sure that you're not dealing with nephrocalcinosis. Because it is a urine calcium create ratio which will help us to decrease our doses of calcium.
Okay, ma'am. So whenever we see routinely patient in our clinic with the clinical findings of genovarum or valgum with double malleolar signs and hand X-ray showing the signs of rickets, so we go for the calcium, phosphorus, vitamin D levels, then the alkaline phosphatase and PTH. So all this investigation we are doing. But my question is, after that, this calcium and create ratio, so do we need to prescribe in every patient, or we have to monitor?
No, not in every patient. No, not in every patient. So especially those patients who are having the rarer forms of resistant rickets, right? And especially in those patients in whom you are prescribing calcitriol.
Okay, ma'am.
right? Because they have a risk of developing nephrocalcinosis. If your calcium levels or your calcitriol levels are too high, the therapeutic levels, then they end up having high urine calcium creat ratios and developing nephrocalcinosis. So to kind of find balance and titrate your doses, you would need to check your urine calcium creat ratios. So now, as a pediatric endocrinologist, my way of looking at it would be different, but it would be okay if you don't do a urine calcium creat ratio at the time of diagnosis.
Yes, ma'am. That's only what I
Yeah.
want to know. So,
Yes.
Thank you so much, ma'am. We don't have any questions further. I think I'll ask Dr. Atul sir to share his screen and start his presentation.
Yes. So I can stop. I can leave, right?
Yeah, ma'am.
Yes. Thank you so much.
Thank you, ma'am.
Just the screen
Good
visible?
morning. Yes. No, sir. Good morning, sir.
Okay. Yeah, good morning. I'll just
Yeah.
on the once more. Let's see. Visible now?
Yes, sir.
Is that okay?
Yes, sir. Yes, sir. We are clearly visible.
So am I audible enough?
Yes, sir. Correct, sir.
Okay. So I'm just going to give a brief overview on the strategies we use for treatment of osteogenesis imperfecta. And I think one of the biggest challenges we face typically is planning of the osteotomy, because there are deformities in multiple planes. Individual bone needs separate planning, and asymmetry is extremely common. Hence, you may have planned separately for the left and the right side. Also, limb length assessment is not easy, especially if the deformity is severe. And hence, standard scannograms may not be possible. So you may have to take sometimes CTs or separate X-rays of the leg. Now, a number of caveats have been already described way back in 2021 regarding the principles of treatment of OI, which are disease-specific steps you must take. So that is that you may have to use single or multi-level, multi-directional osteotomies, depending on where the apices are. Use intramedullary implants over plates. Don't use very rigid rods. Don't use oversized rod. This is not a fracture situation where you need a canal fitting rod, but you just want to make sure that the bones are aligned and the implant elongates. Otherwise, there will be a lot of stress shielding. Other thing is try and do bone shortening. Use soft tissue releases wherever it's possible. In the closed technique, you can do percutaneous osteotomies now to minimize the blood loss. So you can do either both femurs, or one femur and one tibia together. I've found that you need to use supplemental plates, typically for doing non-unions or if you're doing operation around the metaphysis, a metaphyseal osteotomy. So avoid standalone plates and screws, and always, if required, you can use bone graft. And typically, allograft is preferred over the autogenous graft because that quality itself also is poor. Now, what I've learned over the years is that, especially around the hip joint, proximal femur, one need to get a good orientation of the gridded requenter before you make the entry point. So don't try and do it blind if you're not sure, because the GTA often is abnormal shape, and also is the only area which gives solid fixation. Other thing is the bones can be both sclerotic and osteoporotic in the same bone segment. So hence correct sizing is important. Often you need to depend on the intra-op assessment rather than just the X-rays because of the curvature of the bone. Other thing, the periosteum is hypervascular and it is thick on the concave side, and this can be used as a hinge for the osteotomy fragments. And this, I think, is the most important step. Don't try and denude the periosteum completely. Although we've been doing that in the classical Sophie Miller procedure, and I'll show some X-rays where, as long as the soft tissue is intact, the envelope is intact, the bone heals very well. Again, metaphyseal osteotomy areas which are distal femur, especially, you may need to do a supplemental fixation to prevent malrotation. Now, why do we need to put rods? I think the main principle is that once it aligns the bone as well as restores the soft tissue tension, it reduces the tension on the convex side, especially the bending forces, and it's a load sharing implant. So obviously till the bone heals. Once the bone is aligned, the healing is very quick actually, and it can allow early weight bearing. So the idea is to remove plasters as soon as possible to prevent any diffuse osteopenia, and hence you must avoid rigid fixations. Again, if you preserve the soft tissue envelope, the callus formation is very, very rapid, and this really helps us to mobilize these children much earlier. Now, how early do we do the rodding? Typically, rodding is done, earliest rodding can be done between 2 to 4 years. If the child achieves milestones, and the only thing that is preventing the child from kind of standing or gaining milestones is the repeated fractures, and especially in the femur. So typically, I would rod them early. And in the past, we didn't have these telescoping nails, and the smallest size was 4 mm. So I used to use brush nails sometimes, which really helps us. And then we can always tide over and do an exchange nailing later on. Well, there are close techniques which have been described in the manual of the original FD nail. This requires specialized equipments. You need to have a very good imaging intensifier. You need to have good radiolucent table. And then you can do these percutaneous as well if you have this special rod, which is a male introducer. And this helps us to guide the guide wire across bone segments. So this, of course, if the deformities are mild, this is easy to do. If they're very severe and the tissues are very tight, then you have to open them. Again, good imaging is the key, and you can use these indirect reduction techniques. So normally you can use assistant holding the giving traction and holding a mallet to correct the deformity, or you can use appropriate size bed sheets and sandbags just to contour the bone. The key is to get the rod in straight so that there is no deviation when the rod enters the epiphysis. Now there are several options available. We've been doing a rush nail, we've been doing FD nails, dual rush rod was described by Dr. Benjamin. I have not done that. Of the Williams nail, this we were doing when we were doing the fellowship. So as long as you get the bone straight, it doesn't matter what nail you use, but it must follow the principles. And like I said, planning becomes important. So you can plan either by doing some tracing on a piece of paper. You can actually make bone models based on 3D scanning, and or you can use one of these softwares, either the TraumaCAD or the Medicad softwares. At least it gives you a rough idea where to plan your osteotomies. So this is a TraumaCAD software which is used to see the areas where you potentially need the osteotomy. Also, you can measure the distance from the epiphysis. But of course, you need to have true length X-rays. You need to take care of the magnification error, and sometimes it may not be easy to do these things. So once you have this plan in place, at least you know what segments and what distance you would be doing your osteotomy. Similarly, for the upper limb, you can plan the osteotomy. For the humerus, again, you use the same Cora principle. And if there are multiple apices, the Cora will be outside the bone. I'll show you that in one example. Again, important to know the diameter of the bone. The diameter comes from the most sclerotic part at the isthmus. And it may be that there may be internal cortical bone formation, especially in revision cases, which may preclude a bigger size nail. So typically I use sequential reaming, or I use even a bone tap. The taps are very good. You can use, with hand control. Sequentially, you can start with 2.5, 3.5, and you can break the internal cortices to get a bigger canal. But ultimately, what will limit is the sclerotic segment, in which I'll show you some examples of that. Now, if you do the planning, whenever your Cora is outside the bone, that means a multi-apical deformity. So in this tibia, you can see that the Cora is outside, and there are 2 apices. So you have to plan accordingly your osteotomy. You can use K wires to initially mark your site, and then use drill bits and a nibbler, and try and preserve whatever bone you remove. Sometimes you can use the same bone by morselizing it to fill some gaps. Of course, the children, if they've been on bisphosphonates, you may find that the bone can be very, very hard, and hence you have to be prepared to use, good drill bits and taps so that you don't breach the cortex. This is a 6-year-old child with bilateral femoral deformities. We planned this, and it's you can see there are 2 osteotomies required. This child had a recent fracture about 8 weeks ago, and also they had taken a couple of cycles of bisphosphonate. And this we use a 4 a telescoping nail. Also, whenever we make the wedge, remember always remove less wedge than planned. But there will always be some crushing of the bone, so that you don't lose too much length. So whatever wedge you plan, one tip is remove less, and you can always remove more if required. And rely on your soft tissue. The concave envelope is a soft tissue which should be preserved, or at least even if you remove the bone outside, just make sure that you don't cauterize too much on the concave side. This is a child who had a plating done for a metabolic bone disease. He was actually OI, and then he started to bend below the plate because of stress shielding. And then in the initial days, we would plan like this on a true length X-ray, then do the measurements and use the appropriate size nail and rod. So this child actually preserved the plate so that we could make a canal, and this plate served as a cortex. Had I removed the plate, it would have got perforated. So we kept the plate, passed the rod inside, and then did that Wagner's osteotomy, and then removed the plate so that the plate gave us that kind of buttress. Now, open surgeries, you have to do it especially in our situation, because patient presents late. Sometimes we're doing revision surgeries. The deformities are very severe. It gives better control of bone segments, but there is potential risk of bleeding. So you don't combine two femurs in one go. Non-union is rare unless there's infection. Like I said, take care of the periosteum and make sure you have a good team. You have got adequate blood reserved, and you've got good anesthetist who can take care of the post-op as well as the intra-op bleeding. So a couple of examples. This is again a child with bilateral femur. I'll just show examples where this was actually, because the deformity was in the proximal femur, we did a soft tissue release. Make sure you get this kind of view in profile. So before you put your guide wire, you must make sure you get a true AP view of the neck. And then only you pass a retrograde reamer. So this becomes fairly easy because you're doing it from retrograde. Try and engage the trochanter. Should not be too lateral as well. And then you can penetrate with a rush nail to make the track for the male rod to be inserted. And then you slowly start inserting a male rod, and wherever the rod stops, according to your planning, you can make percutaneous osteotomies there, and then advance the male rod down into the epiphysis. Once you got the male rod inside, don't engage the epiphysis very early. In the metaphysis, you can see this bow in the front. This is very, very common. And if you're not careful, you can actually penetrate the cortex. So hence, your assistant must hyperextend the knee for 15-20 degrees, and so that this threads purchase the epiphysis. And you advance the female and the male rod together, so, beyond in the lower metaphysis, so that you don't penetrate the joint. Plating is never to be done. This child had plating done. He had a fracture below the plate, and then we had to revise this to an FD nail. And just isolated plating should never be done. If the child is presenting first time, obviously assess for metabolic bone disease. This child had a simple fracture, then a trivial fall, then came with a second fracture, and both sides he was done plating. I also nowadays do prophylactic tibia rodding as well. So before they get the fracture, I rod the tibia. One may question the approach, but I think it helps to keep to prevent refractures, and helps for early mobilization. Open surgeries were done a lot in the past. This was my earlier cases where the child had a severe deformity, and we had actually done a classical Sofield-Miller procedure where we actually exposed the entire bone, removed the bone segments, and you can see there are almost 5 osteotomies, and he healed really very, very well. These children really heal well as long as the soft tissue envelope is maintained, and they throw very good callus. Similarly, this child who was 8 years of age, again, you can see that we marked the osteotomy with intra-op, make sure we have good control on the fragments. And this child initially had a rush nail done one side, then we did a telescoping nail, and then this rush nail was again revised to a telescoping nail. This was a girl which was 12 years old at the time, and again, bilateral femur deformity, had been operated 3 times, plating done, K-wiring done. You can see these multiple scars, so the canal is very, very sclerotic. This was one of our earlier cases where we did an open osteotomy, preserved the soft tissue envelope, and here she is now. So see, actually, we just had to revise the nails once. Again, I put a rush nail, and she's completely ambulatory. Fortunately, she never had fractures in the other bones. Now we are doing some of these patients. We are doing genetic testing. Of course, it costs a lot of money. So initially, we did about 10 patients free of cost. So she actually had a type 1 OI, which is a milder version. This is another child, 10-year-old child who was bedridden, just used to use a wheelchair, had multiple cycles of bisphosphonates. Again, no rodding was done, which was surprising. When he presented was for the first time, his canals were so narrow, and you can see it's extremely sclerotic. And we could not pass any FD nails in this bone, so we actually used a rush nail and a bent K-wire. And you can see this is actually a K-wire which has been bent, because that was what was only rod which would go inside the intramedullary canal. And this always been, this has been published earlier as well, using K-wires in the past. As long as you use a rod which is straight. This child then, subsequently we had to revise the rods. Again, the canal is narrow, so we changed it to a rush nail. Subsequently, he was walking with the orthotic. Then again, when he came back, we revised his rods again. And here he is now, he's now 24 years of age. So I've always put the rush nail in because his canal is so narrow. And he's now actually doing PhD in Amsterdam. So he's one of our prize patients who've been following up religiously for the last 15 years. These are cases which really, become extremely challenging, because this child had received 20 cycles of bisphosphonates, and the surgeon never decided to treat these children with rodding. And I think that is a pity, because the more cycles you give, actually you're causing more problems. The bone becomes more brittle, and this bone actually was so brittle when you put the rod in, it started to break. You can see here, it just started to crumble. And then we had to just put in a cast on the humerus. We put a rod on the femur, and did subsequently both the tibias as well. The real challenge comes in the proximal femur. The main thing is to understand the orientation. So this classical Fazier's modification has been described, or the Wagner's technique, where you put wires initially, get lever arm on the proximal femur, do a subtop osteotomy, bend the femur, and then pass the rod along the lateral cortex. Now it's not easy as depicted in the pictures. It can be challenging, especially if you don't have the right equipment. And we've had problems when we can't get adequate size rods. Like this girl was extremely small in stature, and we could not get adequate size rods even to insert. So we just had to ensure non-ambulator. So I just did the osteotomy and passed the rod in. She had what is called the Brooks syndrome. So she had contractures. It's a variant of arthrogryposis with OI, extremely stiff and non-ambulator. This child who was a non-ambulator initially because of repeated fractures in the proximal femur. He's the one we did a Wagner's osteotomy. On the right side, we put a telescoping nail. On the left side, he needed the procedure. He's at 3 years follow-up. We just revised his nail recently. He just walks with the help of a walker. He's got some limb length discrepancy, but at least able to weight bear on his own. He recently had a tibia fracture as well, and hence now I'm very particular about rodding these bones prophylactically. There's another child, actually it was an adult whose older sibling died of basal invagination. He almost had 20 fractures. He's from Bhavnagar. Never had any treatment done. He came to us for surgery. Again, extremely narrow canals. We could manage to put just 3 mm rush nails inside. You can see his femur almost like a pencil. So we put a thin rush nail. Like I said, in the metaphyseal area, I put a supplementary plate for derotation. He completely healed up. You can see this is his 2-year follow-up. And then he actually now rides a scooter, and he actually has now joined the National Institute of Design in Ahmedabad for his master's in painting. He's very good in painting. Subsequent cases like these, we've got several of these now. Follow the same principles. You can get bent rods like these as well. When you follow up this length, this has been lengthened almost 6 centimeters. As long as the lengthening, no need to worry. So there's been papers been published from DuPont. Once the rods stop bending, you may have to then revise it. So if there's bending slightly, you can still continue to follow up as long as they're not failing. This was one of the earliest cases I'd done. She was 9 months, I think she was 1.5 years of age when we did the rationale, because she was getting so many fractures, she just couldn't stand. Subsequently, we did a revision. She had also underwent spine surgeries. Again, she came for follow-up, again revisions, and now she is actually 23, walking with a posterior K walker. So these children, if they follow religiously, I think mean time of rod revision is about 3 to 4 years. Here she is taking some steps also independently. Upper limb has always been a challenge for me. It's not easy because of the size of the implants. Recently, Dr. Fazil has described a technique of retrograde insertion of the FD rod. I've not tried this. I've been using slim nails and rush nails in the humerus, and it can be really challenging in the lower part of the humerus. And I've had a few non-unions in the lower part. Problems will always happen, with longer follow-up. So rods can bend, bones can break. Patient don't follow up and rods can cut out. So there are enough reported complications of the FD nails, about 9% complication rate in the series from Toronto. And this is the series from Poland, where they found that the rods usually last up to 3 to 4 years, beyond which they need some kind of revision. And if you rod them very early, before 5 years, there's a high chance of complication because the sizing is not right, the bone anchor is not good. So less than 5 years, potentially you will have more complications. Of course, we've had all sorts of complications because patients present late and rod coming out. This child actually came back from the village with a rod cut out. He never followed up post-surgery. So then he was revised to an FD nail. Rod migration can happen. So even the rush nail, you must always anchor in the epiphysis. Don't leave the rush nail in the metaphysis. You must anchor the rush nail into the epiphysis and the trochanteric cartilage so that it doesn't migrate like this. So this rod was not anchored, started migrating. In this case, the rod came out of the bone itself. So this child had a fracture, the male rod bent and came outside the bone, and this has to be revised again to an FD nail. You can see this bent nail here because of the problem with getting the cutter inside. We have a very crude cutter. It doesn't cut the rod very, very neat. So you can face these problems sometimes. So nowadays I try to exchange rod early before the fracture occurs, if the child can come, if they have been given a date or if they've been warned enough that to come early before they fracture, it's much easier. This is the only time I've used BMP in OI is this child who came from Dubai. He had a non-union of the subtrochanteric area. His bone was so narrow, his canal was so narrow that I use a slim nail. And this is the only child I've used BMP along with allograft. Sometimes I use allograft even in the tibia. If this child had a non-union in the lower area, so we put a supplementary plate, put allograft. So this is well described technique of using graft in OI bones. Like I said earlier, prophylactic tibial rodding is what I prefer to prevent fractures and to get the child walking early. So, and this I learned from Dr. Peter Smith from Steiner's. He used to really nail them prophylactically. I know there's a challenge of revising them, but there are techniques to, with the rescue system, you can revise these nails much easy. So ultimately, the prognosis of walking really not depends on your rodding, but depends on your ambulatory status pre-op, the muscle power, and the soft tissue laxity. Essentially, the rods mainly prevent refractures and preserves the child's muscle strength. So rodding is mainly to prevent refractures and these repeated fractures which can cause problem. So I think the biggest satisfaction comes when parents realize they don't need multiple plasters, so you can rod them early and get them up with the help of orthosis. I think this is the most important thing, physiotherapy and orthotic. Although I mentioned in passing, I think these are integral to the treatment of OI. And if you have a good orthotic support, good physiotherapy support, and now we have got aqua therapy as well. So sometimes we send these children for aqua very early so that they can regain function. So thank you very much for your attention. If anybody has any questions, I'll be happy to answer them on the chat.
So we have one question, sir. How much shortening of bone is acceptable in these cases?
I think as you do more of these cases, you realize that you try and shorten less. You just shorten enough for the rod to go inside without posing any stress on the convex side. So your soft tissue envelope will guide you. So if you're doing an open procedure, becomes much more easy to judge. If you're doing a closed procedure, then like I said, you have to plan the wedges, but make sure you remove less than what you do. And sometimes with osteoclasis, closed technique, you may also get a spiral fracture. So you have to be extremely careful. So I won't shorten them too much. You just judge the soft tissue envelope. That is more important. And I think that will guide you rather than giving a figure. Again, if you're doing multiple osteotomies, more than 2 or 3, don't try and shorten too much, because you want to maintain that soft tissue tension as well. And that actual tension really controls the oozing, it controls the healing, and also your rehab. So if the tissues are very loose, and as it is, these children are very lax, so the muscle power will take a long time to improve. So don't shorten them what is more than necessary, and you can judge the soft tissue tension, especially in open procedure. Closed procedure, again, your assistant should be giving traction. Make sure you've got good alignment and just remove enough wedges that gives you a straight, a straight bone, which can take a straight rod.
Okay, sir. Sir, there is one more question. For tibial roddy, you use antegrade or retrograde technique? And if
Okay.
antegrade, how make a correct entry for a centriform physis, as negotiation guide wire is difficult? And what is your opinion about suprapatellar approach to
Yeah,
get
so there are
posterior?
two techniques which we follow now. Earlier, we used to do the suprapatellar, or what is called now the retropatellar approach, which gives you a straight line. So you don't need to actually make a big arthrotomy cut. And that has been published already with using the retropatellar approach, where you make incision in the suprapatellar pouch area, and you go behind the knee patella and then enter the tibia, which gives you a very, very straight line. Earlier, I used to make, I would do a small arthrotomy so that I would get the correct trajectory. Other important thing is you have to make sure your entry point is not far posterior in the tibia. You have to be just 1/3 from the anterior cortex, so that you don't, your rod should not go posterior. Again, to retrieve it becomes difficult. So you must be in the anterior 1/3 as an entry point. I've done retrograde rush nailing. I've done retrograde slim nail as well, especially when the metaphyseal fragment is extremely small and you don't get much control. And then subsequently, as the bone heals, I've actually removed the rod, cut the threaded portion, and with a suction tip, put the rod back in. So I've learned the technique from Peter Smith, where you can actually use the same rod, and then as the child grows, you can just retrieve the rod from the heel, cut the threaded portion, and then hammer the rest inside the tibia and let it stay there. And if you need to revise it later, you can always revise it as the child grows. So tibia, I prefer now antegrade, a suprapatellar approach, which gives you a straight trajectory. Don't make a big arthrotomy unless you have to revise them. So when you have to revise them, you have to generally open the knee and then try and retrieve the female rod with the help of the specialized screwdriver.
Okay, so that's all the question we have. Thank you for the wonderful lecture and giving an insight in the osteogenesis, imperfecta, osteotomies, and long-term follow-up. Thank you so much.
Thank you very much. Thank you very much.